Hi, my name is Dr. Ben Sessa. I'm a consultant psychiatrist and a trained ketamine, MDMA and psilocybin therapist. Welcome to this Atma teaching module on ketamine-assisted psychotherapy. I'm going to focus mostly on the clinical uses of ketamine and the history of ketamine rather than the pharmacological effects, which will be covered in a different lecture. So ketamine sits in the taxonomic categorization of psychedelics under the group called dissociative anesthetics, alongside other drugs such as phencyclidine and nitrous oxide, all of which are NMDA antagonists. When we look at different conditions treated by psychedelic therapies, for example, depression, anxiety, eating disorders, addictions, PTSD, and personality disorders, we will see that over the years we have seen psilocybin applied to different treatments for different conditions. MDMA has been applied. We've seen pilot studies for psilocybin for depression and eating disorders and PTSD, MDMA for personality disorders, MDMA for eating disorders, psilocybin for personality disorders, and MDMA for depression. So quite a broad range, but none of these are as broad as the range of ketamine, which has been used as the most broad spectrum of all the psychedelic therapies. This leads us to begin to ask the question, are these categorical diagnoses even particularly valid? And in terms of psychedelic psychotherapy, perhaps psychedelics are simply non-specific amplifiers of psychotherapy and therefore would work in all psychiatric conditions, which does make us question the whole concept of psychiatric categorical diagnoses. What we see increasingly these days is the discussion around how all psychedelics promote neuroplasticity and neuroflexibility by providing therapeutic windows. This is particularly true for ketamine, which has a direct neuroflexible response in terms of increasing network connectivity and thereby opening this therapeutic window. By illustration, I'm going to look at three different drugs here: psilocybin, ketamine, and MDMA, all of which have their own unique biological profiles. Psilocybin impairs the default mode network and increases network connectivity. MDMA impairs the amygdala and allows for the trauma memory recall. And ketamine works particularly by inducing protein synthesis growth, and this results in new dendrite growth. If you take a slice of nerve tissue in a petri dish, soak it with ketamine, and look at it with a time-lapse camera, you can actually see dendrites popping and growing as the ketamine affects that nervous tissue. Now, what all of these different drugs do in their own way is they all open this biological window of opportunity through the creation of neuroplasticity, new networks, new connections, and this is a brief, very privileged window of opportunity. And if we hit the patient at that point with bespoke, focused psychotherapy, we have an opportunity to tackle the rigid narratives that allows for psychological change. And it's these rigid narratives that underpin most long-term mental health problems. So ketamine is a very valuable tool in allowing this neuroflexibility, which allows the patient, for the first time in their life perhaps, to tackle this rigidity. Ketamine works similarly to other psychedelic drugs in a therapeutic context. Patients are usually on a bed with eye masks and headphones, listening to music, encouraged to be with the experience. There's very little talk therapy that takes place within a ketamine session. Most of the talk therapy takes place outside of the ketamine session in the non-drug supportive sessions for both preparation and, crucially, integration. Within the therapeutic setting, we use often breath or music or even therapeutic touch to enhance the experience, and the patient is encouraged to just be with the drug and allow the drug to work. It's this non-directive focus in which there's an inner focus that allows the patient to break through the rigidities of their narratives, loosen the ego, and allow this access to the unconscious, which can allow them to work through memories. Now, ketamine, I'm not going to say anything in great detail about the pharmacology of it, as that's covered elsewhere. But it's fair to say that ketamine works particularly by the stimulation of rapid neuron proliferation, increased connectivity between neurons, and this translates psychologically into more opportunities for flexibility, more cognitive opportunities. So where a patient may have all of their life carried around the rigid narrative, I am useless, I am a failure, nothing ever works for me, it's my fault. Typical narratives that underpin depression, anxiety, and addictions in particular. With this growth of new dendrites, this often offers new therapeutic opportunities for the patient to say, well, maybe I'm not so useless. Maybe there are other ways. So that physical change in brain structure and connectivity translates psychologically into new cognitive and emotional opportunities for the patient. And when combined with psychotherapy, this provides a very powerful tool to tackle these rigid narratives. Now, a few brief slides on the history of ketamine. So ketamine is known both as an anesthetic, as a recreational drug, and also in terms of psychiatric indications, both as an antidepressant and as an adjunct to psychotherapy for more broader psychiatric indications beyond just depression. This is a very busy slide, but hopefully you'll be able to see the slides and therefore read this in your own time. So ketamine was initially developed in the 60s as an alternative to a similar anesthetic called phencyclidine, or PCP. Now, PCP is a very powerful anesthetic, but it's also quite long-acting, and it's also very intense and has an increased risk of psychosis. So ketamine was developed as a safer, faster-working option to PCP. And it was used both in humans and in veterinary science in the 60s and 70s. And then in the 70s really took off as an anesthetic of choice, particularly in combat situations. It was used widely during the Vietnam War, where it was called the buddy drug. People were encouraged to carry vials of ketamine and to use it on the battlefield to provide rapid-acting anesthesia. Now, it works as an anesthetic as a dissociative, so it doesn't necessarily kill the pain or affect pain receptors, but the patient is dissociated from their pain. So it's as if I'm over here and the pain is over there, and there's a separation. And it's still used in this way, in the form of Entonox gas, which is nitrous oxide, very similar acting to ketamine, for brief surgical procedures. It's also very widely used as ketamine in pretty much all hospital departments for surgery and minor injuries these days. It's interesting that it has a narrative as a horse tranquilizer when actually it's a widely used human drug. Indeed, it's on the World Health Organization list as one of the top 10 essential drugs used internationally as an anesthetic. If we move on to its use in the recreational drug setting scene, it played very little part in the 1960s drug revolution. PCP did slightly, but that was mostly LSD that was being used back then. It started to become popular in the rave scene in the late 80s and early 90s, where it was being used alongside cocaine and ecstasy in rave scene settings. And then it started to cause problems within that scene. It's not actually very good as a dance tool, ketamine, as it tends to make people quite sort of unambulant. But it was certainly being used as a psychedelic. It got this narrative as a horse tranquilizer, which is frankly ridiculous. Many drugs are used in veterinary science that are also used by humans. My cat was given buprenorphine, and my dog was given penicillin. We don't say, oh, penicillin, that dog antibiotic, or opiates, that cat analgesic. So why we say ketamine, that horse tranquilizer, is very much beyond me, and I urge you all to go out and challenge that narrative when you hear it. So by the 2000s, it was being widely used, ketamine, particularly in the UK and elsewhere. And one of the common occurrences of people using ketamine recreationally is when they think it's a line of cocaine and they snort a line of white powder and it turns out to be ketamine, not cocaine. A very different experience indeed. Now, it's used within psychiatric indications. So in the early 90s, it was used as a tool to enhance psychotherapy to treat addictions by this chap, Evgeny Krupitsky, who widely used ketamine-assisted psychotherapy to treat alcohol and opiate addictions. And then in the early 2000s, a serendipitous discovery was made by an anaesthetist who found that when giving ketamine as anesthesia to patients with depression, they tended to report a better mood and lower depressive symptoms for a week or so after each ketamine infusion as an anesthetic. And so then this led to further research, and it was found to be a rapid-acting antidepressant with no psychotherapy. It just works to improve mood and reduce suicidality. We then, over the course of the 2010s, saw more and more studies addressing the use of not just rapid-acting antidepressant ketamine, but combining it with psychotherapy as a tool in the psychedelic state to assist psychotherapy. And in the early 2000s, we started seeing the late 2000s rather, we started seeing the emergence of psychedelic therapy clinics that used ketamine as a tool. Now, one of the reasons that ketamine rose to the top of the pile was because MDMA and psilocybin to this day remain unlicensed in almost every country in the world other than Australia. And so there's been this huge growth of ketamine clinics all around the world, most of them providing just ketamine-assisted just not ketamine-assisted psychotherapy, just using it as a rapid-acting antidepressant. But a few in more recent years have started using it as a tool to assist psychotherapy. I won't say much about the safety and tolerability of ketamine, as I'm sure this is covered in the pharmacology lecture, but suffice to say, it does have some significant risks. Of all the psychedelics, ketamine's probably the most harmful. There's a risk of addiction. It can, if you use it repeatedly, recreationally, in high doses, it certainly can become a dependent drug with high levels of tolerance and the need to use higher doses. So it certainly has a risk if you use it regularly. Another important risk for ketamine is that it does cause inflammation of the urinary tract, and that's everywhere from the kidneys, both the ureters, down into the bladder and the urethra. And inflammation then heals by scarring, and this can become irreversible. Indeed, it can cause such significant pelvic and abdominal pain that what heavy recreational users do is find the only way to relieve this pain is to take more ketamine, which is, of course, extremely harmful. And once you've had this scarring within the urinary tract, it's irreversible, and many people end up with urostomies as a result of heavy recreational ketamine use. Now, it's important to say that this is unlikely to happen in a clinical setting, given the doses and the frequency of dosing that we use with CAP, but it is certainly a risk in recreational heavy use. Now, when ketamine is used as an antidepressant, so this is without ketamine-assisted psychotherapy, it's very effective as a rapid-acting antidepressant. But as you can see from that graph there, the effects come on within hours, and then they last within days, maybe up to a week. If you're lucky, maybe 10 days at the most. And then the effects drop, and you have to repeat. So you see this sawtooth type graph, whereby you have to continually have ketamine infusions when it's just being used as an antidepressant in order to maintain antidepressant activity, which is valuable in many cases. It's arguably better than some other antidepressants, and it's also considered useful as a tool, as an alternative to psychotherapy, as an alternative to electroconvulsive therapy. But you do have to keep repeating antidepressant use with ketamine in order to maintain antidepressant effect. Now, when we combine ketamine with psychotherapy, it's very different. We're not just using the antidepressant effect. There is still that antidepressant effect there. But by combining it with psychotherapy, as we would other tools, such as psilocybin or MDMA, we actually are enhancing the experience of psychotherapy. And this means we can broaden the indications beyond just depression into other psychiatric indications, including bipolar disorder in the depressive phase, anxiety disorders, PTSD, substance use disorders, and eating disorders, all of which would benefit from ketamine-assisted psychotherapy. Now, a typical protocol for ketamine-assisted psychotherapy would consist of a mixture of drug sessions and non-drug sessions. Now, this is typical for all psychedelic therapy protocols, including ketamine. It's not just taking the drug. Very important, fundamental cornerstone of psychedelic-assisted psychotherapy with any compound. The drug bit's the easy bit. Most of the talk therapy and psychotherapy takes place in the non-drug sessions. So you will start with a medical assessment to test eligibility, and then you will go into preparation sessions, which may go on for 1, 2, 3 weeks. Then you will have usually weekly sessions with ketamine, followed by next day integration sessions, and then you would have a final integration at the end. Now, this course I've put up here is just a generic course. It could apply to any ketamine-assisted psychedelic therapy program. The important thing is that there's this mixture of drug and non-drug sessions. Now, with ketamine, most of the psychotherapy takes place in the non-drug sessions. There's very little therapy that takes place within the drug-assisted session. There's often a change in the dose range during the course of therapy with ketamine. Normally, one would be aiming to reach a dissociative level, but starting slowly with a tolerable dose that the patient can manage, and then reaching that therapeutic dissociative level as you go through the weeks of treatment. Ketamine can be administered orally, or rather sublingually, through lozenges. It can be done intravenously through a drip, or it can be done through a intramuscular injection. All of these have both advantages and disadvantages depending on the type of clinic you have and the staff you have available. The important thing is that we use the ketamine-assisted sessions to enhance the psychotherapy as we go through the course of treatment. It's all about integration. So the drug experience with ketamine is quite variable for different people. Some people at the top end of efficacy will experience a wonderful breakthrough, lifestyle changing, ecstatic, blissful, psycho-spiritual experience. People at the other end of the spectrum may actually not tolerate ketamine at all and find it a very distasteful experience they don't want to repeat. For quite a significant number of people in the middle of that spectrum, ketamine is quite a empty or dark or nothingness type experience, which means the therapist has to work very hard in order to get meaning from that psychedelic drug experience. This is very different from, say, MDMA, where the drug does so much of the work. With ketamine, you have to work very hard as a therapist. So you need to use the ketamine-assisted experience in the non-drug sessions to explore how you can tackle those rigid narratives that go with chronic, unremitting mental disorders. And this is about using this enhanced flexibility, having trust within the therapy model between the patient and the therapist to break these patterns of rigidity and encourage the patient to see new ways of looking at old problems. And it's this enhanced creativity, this enhanced capacity for mindfulness, the ego dissolution effect of the drug that allows them to tackle narcissism and self-obsessions and see the good in themselves and see the therapeutic options and the greater opportunities that that drug experience can have when carefully and meticulously integrated with the therapist alongside the patient. So thank you very much for listening. I hope you have found this an interesting brief introduction to the use of ketamine-assisted psychotherapy. Thank you very much. Goodbye.